Starting to record now.
Great,
thank you. The purpose of this series of webinars is to make sure that the neurology community has access to education on issues important for neurodevelopmental disability care across the lifespan, specifically focused on adults with IDD. We want to make sure that educational opportunities that affect this population, this large population and this overlooked population, is available to our neurologists and to our colleagues. And we feel very passionately about that. And we think that neurologists deserve to have this education and access to this education as a part of their professional development. In order to fill that need, in order to encourage our professional societies to focus on filling that need, we have started a monthly webinar series leading up to the AAN annual meeting. And our monthly webinar series features many issues that we feel are important in the care of adults with IDD. Our first webinar installment was last month about the care of people with CP across the lifespan. And we're really excited today to introduce the second installment of that webinar series on sexual health in adults with IDD. And with that, if I could turn it over to Benjamin Schindel. Dr. Schindel, please take it away.
All right. Hi, everybody, and thanks for joining us tonight. Very excited to have the chance to talk with you. My name is Ben Schindel. I am in my third of 4 years in the Neurodevelopmental Disabilities program at the Kennedy Krieger Institute in Baltimore, and have put together a talk here about sexual and reproductive health in adults with intellectual disability, sort of with the idea that this is intended for neurologists. What do neurologists need to do about, or need to know about this topic? I have no financial conflicts of interest to disclose, but I do have sort of a personal interest to disclose, which is that I think this is a particularly interesting and important topic. And also that this was kind of a difficult presentation for me to put together. In the end, what I thought were kind of the main things that I wanted to accomplish with this talk were, first of all, to provide some definitions so that everybody is more or less on the same page about what we're talking about here. But then to get into the meat of it, and the meat of it would be arguing for the significance of sexual and reproductive health issues in neurology, which is meant to sort of be an overview with some supporting facts and figures. The big takeaway from this is that there are lots of sex and reproduction related conditions with neurologic manifestations, and many neurologic conditions with sex and reproductive implications, but this is not meant to be exhaustive. Similarly, I didn't want to harp on why neurologists, on neurologists caring for people with intellectual disability. We know that there's a lot of overlap. Neurologists take care of lots of patients with disabilities, and so the section about intellectual disability and neurologic care is using epilepsy and intellectual disability as an illustration, but again, not meant to be exhaustive, and really just sort of meant to connect some dots there. But really, the difficult part of this was picking out what's so significant about the intersection of sexual and reproductive health, intellectual disability, and neurology, because it seems to me that knowing the overlap between neurology and sexual and reproductive health is important. And having experience taking care of people with intellectual disability is important, but neither of those in isolation or together are really enough in order to, I think, provide effective care for this substantial portion of the population who are overrepresented in neurology clinics. I think that requires an understanding of the historical context. And so my goal in this talk ultimately is to allow conversations between neurologists and their patients with intellectual disability, especially conversations about sexual and reproductive health care, to be more productive and to be more sensitive, thanks to sort of a knowledge of the history that informs that care. The past really informs the present. So starting off here with the definitions. The definitions are really coming from two sources: the WHO, which has working definitions of the terms sex, sexual health, and sexuality. And those working terms tend to be the ones that are used primarily in the literature I was reading. And then the other source would be the DSM-5, which is where we get our diagnostic criteria for intellectual disability. So sex, according to the WHO, really is talking about the biologic characteristics that define humans as female or male. We know that sex and gender exist on a spectrum, and with respect to that, the WHO acknowledges that these biological characteristics are not mutually exclusive. There are people who possess both, but in general, this is just sort of meant to distinguish people as male or female. Sexual health is phrased very similarly to a lot of other WHO definitions. State of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. And one of the other parts that I just want to point out that I think is kind of significant here is that sexual health requires a respectful approach to sexuality and sexual relationships, free of coercion, discrimination, and violence. And in order for sexual health to be attained and maintained, the sexual rights of all people must be respected, protected, and fulfilled. The last definition we're going to run through here is the definition of sexuality, which was used in the previous definition. But this, the definitions get a little more vague as we get into them. This one is essential aspect of being human throughout life, but encompassing sex, gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction as well. So not all of them are experienced or expressed at all times, and not all of them are going to look the same in different people. They're influenced by a lot of factors, both biological and outside of our own biology. So those are kind of the definitions of sex, sexual health, and sexuality that we'll be using today. As far as the definition of intellectual disability, this is coming from the DSM-5 and really hinges on three main criteria. The first is deficits in reasoning, problem solving, planning, abstract thinking, basically deficits in cognitive functions that are confirmed by individualized and standardized intelligence testing. Deficits in adaptive functioning that kind of limit the functioning in daily life, and an onset of these deficits during the developmental period. So kind of taking these one by one here, because this is a little complex. Standardized intelligence testing performed by psychologists. The commonly used ones that in pediatrics anyway are the Wechsler tests. On these tests, the average score is 100 and the standard deviation is 15. So the way that we define intellectual disability is that the score must be 2 or more standard deviations below that population mean, and that includes a measurement error of about plus or minus 5 points. So that means is that in order to qualify for a diagnosis of intellectual disability, the score on one of these standardized intelligence tests needs to be less than 75, and the range of 65 to 75 is kind of this gray area that's sometimes called a borderline cognitive functioning. The way that we conceptualize the intellectual disability is that this is not an inability to learn, but an inability to generalize what's been learned. And we kind of think of IQ value as the percentage of the cognitive development that we would expect for chronologic development. So if we have an IQ of 50 and a chronological 4-year-old, we would expect that they're functioning cognitively at about a 2-year-old level. So generally attaining 2-year-old milestones, having some of the more abstract thoughts and things that we would expect of a 2-year-old, but not of an age-matched peer. And as we go through that person's life up until about 16, we sort of see that trend continuing. After about 16, things sort of taper off a little bit, which just has to do with the rate of development at that point and the things that we can measure. And so generally, just to make the math easy and based on these trends, we sort of say after about 16, that's leveled off. So our 50-year-old or our 16-year-old with an IQ of 50 is functioning at the cognitive age of about an 8-year-old. And that 16-year-old at 26 and at 40 and at 50 and at 70 is also going to be functioning at about the cognitive age of about an 8-year-old is the way that we sort of conceptualize a lot of this. As far as adaptive functioning, this actually doesn't have a specific definition in the DSM. It's kind of one of those you know it when you see it sorts of things. Basically, is referring to how a person is meeting standards of independence and social responsibility, and always sort of with respect to others who are chronologically matched or matched by chronological age. So in general, adaptive functioning refers to conceptual, social, and practical domains. often can be sort of independent of IQ scores. We have a lot of instances of people with low IQ scores who are able to adapt reasonably well and don't necessarily meet criteria for that deficit in conceptual functioning, so wouldn't meet criteria for intellectual disability. And then vice versa. There are a lot of people who don't have an IQ score below the threshold, but who do have deficits in conceptual functioning. And so we have to sort of be looking for other diagnoses in those cases. There's scales that we use that quantify adaptive functioning, but ultimately it's really just clinical judgment. And then the last bit of that ID definition was developmental period, not defined in the DSM. You kind of know it when you see it. So really the takeaway here is that a lot of this is based on clinical judgment. As far as severity level classifications go, also based on clinical judgment. Historically, severity ranking is mild, moderate, severe, or profound was based on IQ score. And then as of DSM-5, it really became based on sort of the amount of assistance required to function in day-to-day life. It really became sort of this subjective measurement of deficits in adaptive functioning. So getting into the first bit here, I wanted to talk about the overlap between sexual and reproductive health and neurology. And again, this is not meant to be an exhaustive list, but just the point that I wanted to make here is that there are lots of sex and reproduction related conditions that have neurologic manifestations and lots of neurologic conditions with implications for sex and reproduction. So for instance, in pregnancy, we know that there are some inherited neurologic conditions that have implications during pregnancy, like for instance, Charcot-Marie tooth with an increased risk of operative delivery, postpartum hemorrhage. There's a facioscapulohumeral muscular dystrophy. In about a quarter of women in one study, there is irreversible worsening of muscle weakness that actually didn't improve after delivery. And the last one that we have here is limb-girdle muscular dystrophy. Up to half of patients also have this sort of irreversible worsening weakness as a result of pregnancy that doesn't improve after delivery, as well as higher rates of pregnancy loss than age-matched controls. Patients with VP shunts have up to a 50% failure rate, or I should say about half of pregnancies in patients with VP shunts have shunt failure, thought to be due to alterations between the ventricular and peritoneal pressure gradients as a result of changes, intra-abdominal changes from the pregnancy itself. There are new neuropathies, exacerbated neuropathies that emerge during pregnancy, so things like carpal tunnel syndrome and neuralgia paresthetica, and also an increased stroke risk, which is sort of well described in the literature. Epilepsy is another condition that's very commonly brought up in conversations of sexual and reproductive health and its overlap with neurology, primarily to do with the medications that we prescribe for epilepsy. So lots of these medications like valproic acid and phenytoin and carbamazepine are associated with birth defects in offspring. And we also know that there's a much higher failure rate of birth control, or especially OCPs, in patients with epilepsy, which is thought to be due to interactions between some of the anti-seizure medications and the OCP itself. Multiple sclerosis is another condition that in the literature I would say is relatively rich in the literature as far as you know, sexual and reproductive health and neurology literature goes. As far as so within multiple sclerosis, pregnancy seems to actually decrease disease activity, and then there's a relative increase in the postpartum period. There's also a study from Denmark in which almost 600 patients were surveyed, and half of the patients reported that they didn't feel that they had been sort of appropriately counseled about medication options and sort of what was available to them during pregnancy, what would be safe for them to take. But separate from reproduction, there are also primary sexual side effects or effects, I should say, of multiple sclerosis. So by age 50, almost half of patients with multiple sclerosis have become completely sexually inactive, and an additional 20% have had decreased sexual activity. The paper that I was looking at didn't indicate how long after diagnosis or how long after disease onset this occurred, but certainly by age 50 in this sample, this is what they were observing. For women, this manifests primarily as decreased libido, changes in genital sensation, painful intercourse, decreased vaginal lubrication. In men, decreased libido is also present, but there's difficulty with maintaining erections, achieving orgasm, and a change in genital sensation as well. Some of this is due to the primary lesions from the condition, but some of this is also thought to be due to psychological effects of the multiple sclerosis diagnosis. Spinal cord injury is another condition in which there's pretty pronounced and profound sexual and reproductive health implications. So erectile dysfunction is common in up to 75% of males with spinal cord injury. And while there are some ways to mitigate the sort of mechanical issues that arise from erectile dysfunction, there's still a decreased rate there's still a high infertility rate. That high infertility rate is thought to be due to poor sperm quality, sort of in addition to deficits in maintaining an erection. For women, fertility tends to be maintained as long as there isn't disruption to the hypothalamic pituitary gonadal axis, but there can be damage to actual sexual function depending on the area in the nerves that are injured in the spinal cord. So for instance, the pudendal nerve and some efferent fibers, the pudendal nerve serving as an afferent source and efferent fibers coming from S2 S4, as well as some thoracolumbar fibers, are responsible for a lot of the sensation and sexual response in female anatomy. And when those are disrupted in spinal cord injury, that can cause sexual dysfunction. Significantly, patients with spinal cord injuries tend to rate sexual dysfunction as very high on their list of concerns. And then, of course, there's also things like infectious diseases. Neurosyphilis, HIV has many and myriad manifestations neurologically. Herpes manifests as encephalitis, meningitis is in the case of trigeminal neuralgia. We also know that there is a sort of disproportionate, a huge health disparity population in LGBTQ plus individuals. And a recent study that came out in the journal Neurology that suggested that that neurologists recognize that there are deficits in achieving healthcare or activating healthcare, but didn't seem to understand the impact of sexual and gender minority identities on neurologic health. And then there are lots of other conditions as well. Again, like I said, not meant to be exhaustive, just sort of meant to make the case that there is an overlap between sexual and reproductive health and neurology. And there's a reason why neurologists should be thinking about sexual and reproductive health in their sort of comprehensive care of patients. As far as neurology and intellectual disability go, similarly, I think that the case sort of makes itself. There are a lot of neurologists who take care of patients with intellectual disability and recognize that this is a significant portion of the population, or at least if intellectual disability represents somewhere between 1 and 2% of the general population, that's certainly overestimated or overrepresented in neurologic practices. There is a significant overlap between epilepsy and intellectual disability. I wanted to sort of hinge on epilepsy because I thought that the literature was quite good for this, as well as the the sort of using epilepsy as kind of like a model condition for neurologists. So 25% of people with epilepsy are thought to have a comorbid intellectual disability. And on the reverse side, about 20% of people with intellectual disability have a comorbid epilepsy, with increasing rates depending on the severity classification that we talked about before. If I remember correctly, this sort of dose response effect kind of thing with the ID severity classification was using the older criteria. I might be wrong about that, but the point is certainly as we get into increasing severity of intellectual disability, the rates of comorbid epilepsy increase. People with intellectual disability, people with intellectual disability and epilepsy have greater risk of stroke, elevated risks of speech and motor disabilities, and elevated risk of joint disease and GI illness when compared with patients who just have intellectual disability but don't have the comorbid epilepsy. And then sort of on the reverse side, patients with epilepsy and intellectual disability have an increased risk of developing dementia compared with patients with just epilepsy. Although in a lot of this literature, it seems to be more or less syndrome specific. So I'm not sure that that generalizes as well. The epilepsy in patients with ID can be difficult to treat, often presents sort of with associated anxiety and mood disorders, and there's a higher rate of psychogenic non-epileptic seizures in a lot of these patients as well. There's a high rate of memory and executive functioning problems that seem to exist before epilepsy diagnosis, and certainly are enhanced by some of the medications that we give for epilepsy and some of the procedures that we perform as well. So the International League Against Epilepsy has actually recommended prehabilitation for about 5 years now. And the idea is that if we anticipate post-operative changes in cognitive abilities, we might be able to start training patients before, and training is kind of an interesting word, but might start being able to work with patients before the surgery to identify what the outcomes might be and help them to develop workarounds so that they're not as functionally impaired as they might otherwise be. So, sexual and reproductive health then in people who have intellectual disability. This is where I was really getting stuck, because I wanted to make the case that neurologists manage patients with intellectual disability, right? And I think that's a thing that is somewhat evident, I hope. I wanted to make the case that sexual and reproductive health is important for neurology, and I think there are many examples of ways in which that shows up. But where this all intersects became it was something I was really kind of hung up on. I wanted to make sure I was doing right by this. When the answer actually walked through the door of my clinic very recently in the form of a 25-year-old young man who has 2 genetic mutations, SCN1A, and he also has a microdeletion on chromosome 8p. This young man has a severe intellectual disability. I would estimate that at 25, he's operating at about a 3 to 4 year old cognitive level. His epilepsy actually diagnosed with Dravet syndrome due to the SCN1A mutation. And he also has some musculoskeletal abnormalities, so microcephaly, crouched gait. His epilepsy for a while was very poorly controlled, but at this point we have him on Depakote, and he also has a vagal nerve stimulator. And so he came in for sort of a routine visit, and we were not really making any changes. Not making any changes to the Depakote. I was changing up some of one of the other medications that he's on for some behaviors. And as I was walking out of the room, his mother asked me about the process of getting this patient a vasectomy. And I just thought that that was such an interesting conundrum to come up with, because it turns out that this patient, since the last time I saw him about 3 months ago, now has a girlfriend at his day program, and he's expressed that he's interested in having some private time with her. So his mother has established very specific boundaries about when he is able to spend time with this girlfriend and when he's not, and what kind of oversight he has to have. And she has established those boundaries in such a way that she's quite comfortable with them, but can't be sure that the workers at the day program are going to respect that. She can't be around him all the time, so she doesn't know that these will be respected. And if in the event that he did have a child as a result of time spent with the girlfriend, he would not be able to care for that child himself, and she would wind up having to take on the care of an infant. He has multiple younger siblings at home already, so I mean, this is not something that she's signing up for. So in handling this, I think that there are a number of things that I wanted to spend some time talking about, because the answer really is informed by the historical context here. Specifically, the history of autonomy as an ethical principle, and sort of the ways that that's been neglected and abused, especially most extremely in the history of eugenics. The story of Roe v. Wade and the recent Dobbs decision and the impact that that's had on the population of people with intellectual disability, or just disabilities generally, growth attenuation practices, and general statistics about things that are sort of known to be associated with intellectual disability, like, for instance, high rates of sexual abuse. So starting here with the ethical principle of autonomy, which dates back to ancient times, but has sort of an interesting history as it's developed into its modern form. So autonomy refers to the capacity of a patient to make informed, rational decisions about their medical care, and extends to the practice of informed consent, which we'll discuss a little bit more in a moment. There's a sort of, in history, up until about 1870, a lot of most doctor visits were done in the home, and doctors who wanted to try new experiments and try new things didn't necessarily need to inform their patients, and also tended to have very good relationships with their patients. Over the 50 years from 1870 to 1920, there were kind of two main changes that drove a big shift in medical culture. So the first was that the number of American hospitals started to increase, and increased actually quite a bit. By 40 years after the end of that shift that I was talking about, there are fewer than 1% of patient visits were accomplished in the patient's home, and it's fewer certainly than that now. And the reason for that is varied. I mean, in some cases, it's because it became less feasible for doctors to travel and more feasible for patients to travel to where the doctor was. But also, as medical technologies grew, it wasn't really feasible for doctors to carry things like CT scans and MRI machines to where the patients were. So number of American hospitals increased and kind of changed the workload on the doctors and changed the relationship between doctors and their patients. At about the same time, or sort of concurrently with that, the American Medical Association established standards that kind of could be used to make physicians liable under malpractice principles. They were trying to eliminate quackery in all its forms. And so, we're talking about 1870 to 1920. Well, early medical litigation cases started to arise then. And the first few, 1905, 1906, 1913, argued primarily about implied consent, bodily integrity. And then in 1914, in the case Schlondorf v. Society of New York Hospitals, Justice Cardozo wrote the sort of terminology that ultimately laid the groundwork for informed consent, that every human being of adult years and sound mind has a right to determine what shall be done with his own body. And the sort of second part of that is in keeping with the liability element that started to come out around this time. And then fast forward a few years, 1945, 1946, the Nuremberg Code is established in response to a lot of the human atrocities that the Nazis had carried out in Germany and sort of throughout Europe. The Nuremberg Code established kind of three main principles that are relevant for us here. The first is the requirement of the voluntary consent of human subjects, that research subjects need to be able to exercise free power of choice and have to be informed about the subject matter in order to make the decision an informed one, or an understood and enlightened one. And about 20 years later, this was sort of modified and expanded in the Declaration of Helsinki. In spite of this, doctors and researchers all over the place were continuing to carry out experiments and very often violating these codes. There's an article from 1967, I think it is, in the New England Journal of Medicine that makes sort of a list of violations of medical sort of informed consent principles and violations of patient autonomy. Included in these, and sort of filtered for cases that specifically involved subjects with disabilities, there were, in the United States, anti-malarial treatments that were tested out on patients who were insane and actually in many cases had cognitive deficits and intellectual disabilities from childhood. Infecting children with disabilities with the hepatitis virus, again, in a state hospital, and in an inpatient children's center, inducing liver injury with a medication for, actually forgetting exactly what it was for, but in children who had what were called mental deficiencies. Oh, there it is, 1966. So Henry Beecher publishes Ethics in Clinical Research, and this is a paper in the New England Journal. And as he realized that this was meant to really only be consumed by physicians, he reached out to the press prior to publication, so that it became a study that was known outside of just the medical community. He was kind of spilling the beans a little bit there. In 1971, there was also a really interesting and sort of significant situation, which was that there was a baby born actually here in Baltimore, right across the street from where I am right now, at Johns Hopkins, who had Down syndrome and duodenal atresia. And the parents elected to not perform or not approve surgery on the patient for the duodenal atresia. And at about 15 days of life, the baby died of dehydration. They actually kind of like withdrew care before this. In collaboration, so the chief resident at in pediatrics at Johns Hopkins at the time reached out to the Joseph P. Kennedy Foundation and Eunice Kennedy Shriver, and who funded a like 10-minute film that's available on YouTube. I'd be happy to send the link out to anybody's interested. The film's called Who Should Survive. It kind of just recounts that case. But between this publicly advertised in some ways and study from the New England Journal of Medicine and this documentary that kind of like dramatized and told the story of this kind of like very difficult ethical situation at Johns Hopkins, the public became pretty outraged, and there was a lot of sort of fallout from these two things that resulted in the National Research Act establishing the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research in 1974. 5 years later, they published the Belmont Report, which includes the regulations that establish the ethical principles we know today: respect for persons, beneficence, and justice. But there's also, we can't really talk about autonomy without also, or can't tell the story of autonomy without telling the story of the extreme example of non-autonomy that is eugenics. So eugenics dates back to 1883. The word itself actually means good birth and refers to improving the human race with selective breeding. Again, dates back to 1883 to Europe, and Francis Galton, who's actually a cousin of Charles Darwin, and was kind of basing his eugenic principles on things that he was reading from his cousin's writing. In the United States, in the early 1900s, the ideas of eugenics really became, they kind of took off because there was a lot of wealth and a lot of brain power and control in the United States that funded much of the research and funded much of the movement. A couple of the very significant bits in eugenics history, starting with 1896. Connecticut was the first state to start putting any eugenic principles into its legislature by forbidding people who were epileptic, imbeciles, or feeble-minded from being permitted to marry. That was the language at the time. And about 10 years later, Indiana enacts sterilization laws. This was after two failed attempts in 1897 and 1905 by Michigan and Pennsylvania. So slowly, eugenic principles are kind of creeping their way into the state legislatures. And then if we fast forward to 1927, Buck v. Bell is the sort of next step in that sequence. So we'd approved the sterilization of people with intellectual disabilities, but Buck v. Bell actually allowed for forced sterilization laws with the idea that it would protect the health of the state, in this case of Virginia. And actually, it's still on the books in Virginia officially. So Oliver Wendell Holmes, who was Chief Justice at the time, wrote 3 generations of imbeciles are enough. And I have a photo here of Carrie Buck and her mother, Emma Buck. Carrie had a daughter who was sort of questionably accused of or diagnosed with epilepsy and intellectual disability, and she died very young. She died at, I think, 8 years old from a pneumonia. But there really is not strong evidence that Carrie's daughter had an intellectual disability. And actually, in fact, there wasn't really strong evidence that Carrie herself had an intellectual disability. Much of her being called epileptic and of questionable moral principles, which at the time was kind of an indication of cognitive deficits, had to do with her having a child out of wedlock, and that child was born out of wedlock as a result of Carrie being raped by one of her, the cousin of a family that was taking care of her at the time. So this is where the eugenic movement is at. It loses a lot of steam in the following 10 to 20 years because of, again, the Nazis who really took on a lot of those eugenic principles and pointed to a lot of the laws that were being passed in the United States and pointed to a lot of American eugenic publications and things as their models. So it became a lot less popular in the United States, although it still remained decidedly active. Between 1907 and 1963, so almost 20 years after over 20 years after World War II ended, 64,000 people were forcibly sterilized in the United States, and 2/3 of those sterilizations were performed on women. It really kind of continued until about 1974. So there was a case in Alabama, Ralph v. Weinberger, in which two girls who were 12 and 14 years old were sterilized by the government. And it turned out that when their mother had signed the consent form for their sterilization, the mother didn't know how to read, and so she was told to sign on the X, and she actually thought she was signing up for Depo-Provera shots for the girls. So the family sued. The state of Alabama were forced to revise their guidelines, and 5 years after the case, they came out with these guidelines, which include the stipulation that patients with severe mental impairments who could not give consent could not be sterilized. The two girls in the case were not intellectually disabled. They were Black, but the guidelines themselves kind of were a little more broad-reaching and kind of got at the spirit of a lot of the issues that were going on with this at the time. But I also want to point out that the graphic to the right is one that I found that was published earlier this year. Forced sterilization actually is still on the books in a number of states in the United States. It's not practiced openly as far as we know, but it's on the books at least. And we also know that there have been some sort of updates to reproductive rights this year as well. So this is January 23rd, 1973, the New York Times summary. This was the day that Lyndon Johnson died, or the day after Lyndon Johnson died, so I had to do a little bit of PowerPoint engineering here. But one of the other major events from that day was that the Supreme Court ruled in favor of what became ruled in favor of a woman's right to obtain an abortion, and this was the Roe v. Wade case. And we can fast forward to June 25th of this year when Roe was overturned. I don't want to spend too much time on this. I'm kind of keeping an eye on the time here, but with respect to people with disabilities, the American Association of People with Disabilities issued a statement after the Dobbs decision was announced, and included a couple quotes that I think are particularly illuminating now, given the information that we have about the history of eugenics and the history of bodily autonomy. So, for instance, this first quote: "Bodily autonomy is a core principle of the disabilities rights movement. Disabled people have fought hard to win respect for our capacities and the right to make our own decisions." Separately, the second quote here: "This decision is deeply conserving because of its potential implications for lots of things, which include sterilization and medical care." So the American Association of People with Disabilities statement actually was very much informed by the history that we were talking about. And then there are also other kind of interesting and important things that come up frequently when in relation to sexual and reproductive health in people with intellectual disabilities. So growth attenuation is a medical treatment in which high-dose estrogen therapy is given to prepubertal and pubertal patients of any gender. And the idea is that the estrogen closes the growth plates and sort of halts growth, and it can halt growth by up to 13 inches in some cases. This is a treatment or a therapy that was developed back in the 1940s for acromegaly, and then kind of became used for more cosmetic purposes in the 1960s. So at the time, women, the sort of standard for attractiveness in women was not to be particularly tall, and so there were parents who would give estrogen therapy to their daughters in order to halt their growth for sort of future attractiveness purposes. And it kind of fell out of favor at some point after that, about 10 years later. But then in 2006, there was this article in the Archives of Pediatrics and Adolescent Medicine that was kind of digging up growth attenuation again, in an article that was called Attenuating Growth in Children with Profound Developmental Disability, a New Approach to an Old Dilemma. So the patient that they were talking about in this case report is known as Ashley X, who was 6 years old at the time and was diagnosed with a severe, irreversible neurologic and cognitive impairment. At the time, so she was, again, 6 years old, had an unremarkable pregnancy and delivery, but became very hypotonic, had some feeding difficulties and chorioapatoid movements. Her diagnosis initially was static encephalopathy with marked global developmental delays. But she was thought to not have any signs of being able to grow and develop beyond about infant level. About 6 months or so is what they were anticipating. Separate from her developmental delay, or related to the developmental delay, she was fed through a G-tube and was being seen by the endocrinology department in Seattle because of precocious puberty. And so it was that endocrinology department that initiated the growth attenuation therapy for her, with the argument being that achieving growth attenuation while she's young and hasn't grown too much would make her more able to participate in the activities that her family wanted to participate in, and that she would be able to participate in at a more manageable size. The article itself is another one I'm very happy to send out to anybody who's interested, because it's really fascinating. Since publication, her parents, so Ashley's parents have championed what they call the Ashley treatment. So she, and actually I should sort of redo these slides a little bit. The hysterectomy that she had was actually done before the estrogen therapy was given. It was sort of meant to mitigate side effects. But she has also since had an appendectomy and bilateral breast bud removal. And this very busy slide is copied from pillowangel.org, which is her parents' blog, in which they discuss the Ashley treatment. They discuss a lot of kind of elements of why they decided to do this and what her life has been like. They haven't updated it since about 2015, as far as I can tell, but it's also a board for people who have children with disabilities who in some cases want information about or are having their children undergo growth attenuation therapy. And Ashley, who's still alive and is 25 years old now, was found in 2018 to have a de novo SNP in the GRIN1 gene. It's a mutation that's associated with developmental and epileptic encephalopathies. This is one condition, but this condition here is autosomal recessive, which is, I think, not what hers is. Regardless, it's known to be associated with the kind of disabilities that she has. It was not known at the time. So this became very, very hot when it came out. There was a sort of legal rights group for people with disabilities who brought charges, who accused Seattle Children's Hospital of breaking the law by sterilizing the disabled minor. I mean, they were making the eugenics argument. And while the Children's Hospital didn't get charged ultimately, they haven't approved growth attenuation since then, and they've really sort of cracked down on that. The last sort of thing that I want to cover here, and again, keeping an eye on the time, is that there are other things that inform questions from parents and caregivers about sexual and reproductive health in patients with intellectual disabilities. So one of those things is that we know that patients with intellectual disability are much more likely than the general population, and in fact, even more likely than people with other disabilities, to be victims of sexual assault and sexual abuse. This was a study from NPR back in 2017 or 2016 that used data from the Bureau of Justice Statistics. We also know that pregnancy rates tend to be a little bit, or the age of pregnancy tends to be younger in women with intellectual disability compared with women without intellectual disability. So this is one study from Sweden. The mean age of women with intellectual disability was 24.2 years, and for women without intellectual disability was 28.3 years. There were other factors that were sort of present here, including more adolescent births by quite a few for women with intellectual disability compared to women without intellectual disability, as well as a much higher rate of women with intellectual disability not living with the father of the expected child. There's this very interesting concept or theory called counterfeit deviance, which is the idea that atypical situations beget atypical behaviors. So people with intellectual disabilities tend to live in these sorts of atypical situations, like group housing or institutions in some cases. And their behaviors that sort of appear as paraphilias or appear as sexually deviant are actually completely unrelated to sexuality or to sexual urges, but certainly open them up to risk for all sorts of things, including problems with the law. So, one of the this paper, which again is one of the very interesting ones, I'd be very happy to pass out, includes things like not having a lot of privacy in care facilities, leading to mimicking behavior that could be seen as inappropriate in other settings, which could do with exposure, or it could do with sort of hygiene practices that are not meant to be on display in public. There's also this lack of privacy in general for a lot of patients with intellectual disability, or a lot of patients with disabilities who live in these sort of atypical situations that can manifest as behaviors outside of those situations that can be seen as sexually deviant, but are not that way in real life. But I also think it's really important here to make sure that we remember one last thing here, because I've talked a lot about people with intellectual disability as sort of, victims, or as people without this autonomy over their bodies. But there is one more WHO definition that I think is pertinent here, and that's the definition of sexual rights, which is sort of vague, but what it gets at is that all people should have the right to fulfill and express their sexuality and enjoy sexual health with respect for other people, within a framework of protection against discrimination. And to that end, it's important to know that people with intellectual and developmental disabilities have sex. They have consensual sex in many cases. They express interest in having sex. They're often not given the opportunity to learn enough about sex or consent and boundaries and STIs, but they are people who exist as sexual beings. There's a residential facility in Serbia that was studied back in 2017, I think. Half of the patients, or half the people living in that facility had a sexual partner at the time of the study, and 80% had a history of sexual experiences. Again, with the idea that we know that that there's a high rate of sexual abuse in this population, that number can be a little bit concerning, but much of what was discussed in that paper is that the sexual relationships that were existing tended to be consensual. There was another study in which 84% had sexual relationships. Only 41% felt that they were sexually satisfied, but these were consensual and willing situations. And I think that that's important to say here, that we have to remember that this population is not victimized only. So to summarize here, there is a lot of overlap between neurologic practice and sexual and reproductive health. And knowing about sexual and reproductive health informs the way that neurology gets practiced in terms of diagnosis, management, and communicating with patients. Neurologists care for lots of people with intellectual disability who are people who have the right to be sexual beings and are sexually active in many cases, although that sexual activity is not always of their own consent and not always on their own terms. And I think that's important to know. as is the history of sexual and reproductive health in people with intellectual disability, because it's fraught and long and really informs a lot of the way that they and their parents and caregivers navigate this topic. And so with that, I want to just say thank you for your time, and we'd be happy. All right, got in just under the buzzer here. We'd be happy to take any questions or discuss.
Awesome, Ben. Thank you.
Thank you.
So maybe we can open it up. People, if you would prefer to just unmute and ask a question, that's great. Put a question in the chat, whatever you feel comfortable doing. I see that Seth has a question. Ben, can I ask you to unshare your screen so we can all be in this room together? Okay, go ahead, Seth.
Ben, I mean, this is great. I mean, it's such an interesting topic that probably most physicians, neurologists, I mean, wouldn't even touch or think about. But I think inherent in much of what you're talking about is inherent biases and stereotypes. You know, we go into this, you know, already thinking, oh, they got an IDD, they don't do this, they don't do that. So, I mean, can you make a comment about the reality of stereotypes and biases in this population?
Well, I think that there's a history of really infantilizing a lot of patients with intellectual disability, and you know, infantile patients are not thought of as sexual, and you know, and the fact is that that's actually not the case. I mean, we have data and we have evidence that supports the idea that people with intellectual disability do have sex and do have a right to have sex. But yeah, I think that that's a, you know, it's, your point is well taken, that a lot of what informs the way that these conversations are had is a bias. And I think it's important to sort of address that and to know both why that exists and also the ways in which that bias is incorrect.
Yeah, thank you.
Yeah, thank you.
We have a question in the chat, Ben, from Laura Kirkpatrick. Excellent talk. What do you think is the role of the physician, particularly the neurologist, in discussing the risk of sexual abuse faced by people with ID?
I mean, I think that's a great question, because, you know, ultimately whose problem does this become, right? There is this, you know, is this the issue of social workers, the issue of the primary care provider? Is it, you know, the issue of you know, the OBGYN, if there is one? I mean, there are a lot of people who could potentially take on the risk of sexual abuse, or take that on as sort of a primary thing. I think that the relationship between physicians generally, and I would make an argument that neurologists in particular, with patients with intellectual disabilities, sort of positions them to be the ones to drive that conversation, or to have the relationship in which they can do the screening for sexual abuse. You know, it should be a safe environment, and it should be a situation in which there are resources that are available for intervening right then and there. There's a paper which actually was referenced in one of your studies that came out earlier this year, that has to do with lots of patients with chronic neurologic diseases seeing their subspecialists, and particularly seeing their neurologists as primary providers. I think that that's a very telling study. It's a very telling article, because patients have a tendency I figured you would know that one. Patients have a tendency to see their providers, patients who have a tendency to see their providers as primary are probably more likely to be a little more forthcoming. And so I think that, you know, somebody has to screen for sexual abuse. I think neurologists are actually uniquely positioned to do that.
Go ahead, Ben.
Hi.
Hey, I just, Ben, I just want to commend you. I'm sorry, I'm under the weather, but I just want to commend you 100% for boldly going where so many people are afraid to go with their patients, with or without intellectual disability. Just it's a really hard thing to talk about, and to so respectfully and openly and inclusively, you know, be open to this really important part of people's lives is so needed. And I hope that your comfort and your eloquence in speaking about this is, you know, only spreads. Thank you so much. As far as, you know, the sort of fraud issues, I don't know if this is because I work so much in psychiatry, but I have to formally approve sexual consent in a lot of people. And so, like, you know, I was thinking about that issue, not just with, you know, when your patient came in, you know, not just the question of does his mother have the right to decide for him whether or not he's going to have a vasectomy, but how are we assessing consent at Kennedy Krieger and in Baltimore? How are you assessing consent in both the individual you were treating and his partner? Because if parents disagree, especially if they're living in a congregate setting, you know, for them to be able to have unsupervised time, it's really kind of fraught. And I also get at work, asked at work to assess safety in the community with a lot of sex offenders with intellectual disability. And I'm not forensically trained, but I was curious if that comes up in neurology or in peer neurology clinics, Kennedy Krieger as well, because that's another issue of restricting someone's autonomy. And yet also there's I know that's a totally separate and giant topic outside. But first to start, what do you guys use to assess consent when you're asked?
Yeah, I mean, that's a really good question. I'll be honest, I off the top of my head don't know the answer beyond my own sort of, you know, clinical thoughts and clinical experience. That's something I'd be interested in looking up and getting back to you on, if that's okay. Or Dr. Sato also can weigh in on that.
Well, there's no official kind of pathway right now, but there will be a protocol to really assess the capacity for informed medical decision-making that does involve cognitive assessment by two separate individuals, because I do agree, Ben, this is really an ethical and also clinical dilemma as to, you know, making sure that a young man could make this type of choice, you know, with all the information in hand, and also helping him understand the benefits of it. And, you know, and this is someone, I think you had mentioned, Ben, that the parent had not assumed any guardian or power of attorney role.
Right. So in this specific case, there was actually sort of a more direct route that I had for talking to this parent, which had to do with some of the legal aspects. So, you know, I left out of the case because I didn't want to kind of dilute the ethical gray zone conversation about this. But realistically, the mother doesn't have guardianship and doesn't have power of attorney, so actually has no legal decision-making capacity over the patient. So it's actually a lot more straightforward. He's not interested in it, so he won't be having that at this point.
Okay. But as far as his ability to, yeah. Okay. So medically, right. It sounds like at Kennedy Krieger, there's a two-person process for evaluating someone's capacity to consent for medical procedures. Is there a separate or additional assessments that are done for sexual capacity? Or are they it's, you know, once you have capacity for or once you're determined to have a capacity to consent for medical procedures and medications, then sexual capacity is assumed as well?
I don't know the answer to that. I will get back to you on that, but I don't know the answer off the top of my head.
Yeah, sometimes it's different, and you know, sometimes different agencies have different standards. Very often states have their state agencies have specific protocols that they'll utilize to be able to determine sexual capacity. And there's a few different evaluations. The one that the agencies around me use, I can't remember what it stands for. It's called the SKAAT, the SCAT. and it asks about understanding of anatomy, understanding of pregnancy, understanding of STIs, and then it can be numerically scored. And then there's the ability to summarize what someone would need to be able to meet certain standards for degrees of sexual capacity. But like respecting somebody's autonomy, regardless of whether they may be ready to be with another person, is still totally valid, and I totally respect. There have been some people that really have fought for their right to have access to online materials, printed materials, or objects that they use that have been restricted. They've been there, that feels totally unnecessary. But then there's other individuals that when given access to online materials have demonstrated that they present legal and safety risks to others, even those situations. So it's I guess what we just need to do is just be brave enough to talk about these things without judgment and with respect for autonomy as much as is possible.
I think on that note, that really wise statement from Ben Margolis, I'll call it for this session. Thank you so much for joining us. Dr. Shindell, thank you so much for giving us that wonderful talk on this incredibly important topic. I hope that that Dr. Shindell has spearheaded a conversation that has impressed upon all of us that neurologists, that this is our lane, and this is something that we need to learn more about as a community, as a neurology community, and something that we compel not just niche groups to take interest in, but this is something that should be integral in neurology education across the board, and something that our professional organizations should take the mantle of. So with that note, we will see everybody next month for our next webinar installment. All of these webinars happen on the 3rd or 4th Tuesdays of the month at 5 p.m. Central. And we look forward to seeing you then. Thank you so much, everybody.
Thank you, everybody. Have a happy and healthy holidays.
Okay, thank you, everybody.
Thank you. Bye-bye. Great, Ben. Very good. Thank you.